absolute masters of pediatric neurosurgery who are speaking, who require very little introduction. But Gianpiero Tamburrini is a professor of pediatric neurosurgery at Università Cattolica of Rome. And he will be presenting that bony decompression alone is sufficient for Chiari 1 malformation and syrinx. And then arguing the other side will be Dominic Thompson, who is a lecturer at the Institute of Child Health and at the Great Ormond Street Hospital. And both of these gentlemen are known to all of you. And without further ado, Gianpiero, please take it away.
Hello, good morning and good afternoon and good evening to everybody. And so let's start with our view here at Catholic University. We still do think that bone decompression alone is enough. Also, in the great majority of children with symptomatic Chiari 1 malformation and syrinx. At an age, we were asked at this time of an end of completion of the school growth, 10 years, which is a good thing because we are not dealing with a very small baby, which I think are more difficult to give the correct indication. It should be even case by case, not always be bony decompression alone. But we have a 10-year-old guy, and I will show you some example of the cases that we have dealt here at Catholic University, starting from what I call the easy and debatable case, a primary, because we will start with primary Chiari 1 malformation in, again, an end of school development child with a quite small hydromyelia. You can see here, it's between the cervical spine and the thoracic spine. This is enlarged, this is an axial view of the Chiari malformation preoperative, and the patient was having pain, traditional pain, but also with the severe central apnea with the NHI grade 3. So this was the result of after 9 months, the MRI with the Chicago clinical outcome score, which was almost perfect, considered excellent. So this is exactly the case we will not debate. We will propose bony decompression alone, and we think that these are the cases that bony decompression in almost all cases will be successful, also in making the syringomyelia disappear in a few months. But let's see another case, less easy, that again we still would go for bony decompression alone. 9.5 years girl. They are all girls in the examples. I don't know why, but in the cases of our experience, there were many girls. And with nuchal pain and symptoms, she had a severe ataxia. You will see here the preoperative images with again, Chiari 1 malformation, no alteration in the front of the cervical spine, certainly a bigger syringomyelia, but focal syringomyelia. On the below part of the slides, you will see the postoperative MRI at 9 months with still some occasional nuchal pain, which was the only thing that was referred after 9 months by the girl. She completely recovered from the ataxia. And we see, if we follow this girl in months, the result of the syringomyelia will further improve. And also, in conjunction with this, the girl also has an improvement of the nuchal pain. We can see, or only with bony decompression, that there is some CSF flow back to the tonsils, and the syringomyelia further reduced the insides, almost became very near to be an hydromyelia. So it may take a longer time with the bigger, larger kind of syringomyelias in this kind of patients, but it will happen. So we judge particularly on symptoms more than rushing against the MRI scans. And if the patient is okay, we go on and look at about that. And you see again, the same girls, if we wait a little bit more, the reduction of the syringomelia will continue. This is the last MRI that the girl did just 3 weeks ago. It is at 6 years. It's just a control check that we do in all cases after a few years, just to be sure, even if the patient is asymptomatic, as she is asymptomatic. And this is the final results, the actual results of this scale, which has a Chicago Chiari outcome scale now, which is 16. So she recovered completely. But let's go to the really debated cases. Again, speaking as first thing of primary Chiari 1 malformation. Same age, but with a larger and multi-level syrinx. This is almost 10 years old girl, again, with pain, traditional pain, tetraparesis. And this is the MRI before surgery, okay, which you see on the upper part. And after 1 year, you see that the result is not that convincing in terms of reduction of syringomelia. Syringomelia is almost the same as the preoperative, but the patient, the girl, really recovered with rehabilitation and only had a residual moderate difficulty in fine movements in the hands. At this time, in spite of seeing the clinical improvement, we proposed to go ahead with a more invasive surgery. And the patient family said, yes, we will come next month, we will come. Then every time we called them for the second surgery, they said, no, we cannot now, we will come next month. So this led us to arrive to almost 2 years from the surgery, and we started to see some reduction, in spite, again, that we did propose a second surgery with duroplasty as a second step surgery in this kind of patients. This was the MRI. So at this time, thanks to the rehabilitation, almost all movements were normalized. The child, the girl, had only occasional nuchal pain. So at this point, we discussed it with the family, but we still were not convinced that the result was enough, because the time was quite long, 2 years, and we still saw some syringomelia. And the patient at this point said, why, seeing that we have improvement in clinical and also you say on the MRI? And our answer was just to prevent that it will worsen, maybe it worsen. And so we went again ahead with this discussion. And this is the MRI after 3 years. On the backup, you see the MRI after 2 years, still with some conviction by us to do a second surgery, and below after 3 years. So really, in this case, was a little bit against our second indication, but demonstrated, documented that maybe also with larger syringomelia in a patient in good clinical condition, we may wait just after bony decompression, and it may happen, even if your indication is to go ahead, that the syringomelia slowly will go away. So this is the after 3 years now follow-up with this girl. And another case similar to the previous one, again a primary Chiari 1 malformation of a similar age with a larger and multi-level syrinx. Again, tetraparesis, clinically thermodolorific parket hypoesthesia. Well, you see, again, we indicated to do bony decompression as first surgery also in this girl, but at 3 months she had an insufficient improvement in motor and sensory function. The pain worsened, so we did an early control MRI that actually showed more or less, I would say, the same size of syringomelia compared with before. So at this point, we indicated to do a surgery of duroplasty in this girl, and she, the family accepted to go ahead with this kind of surgery. And so this is before, on the upper part of the slides, before posterior fossa osteodural decompression, and after 3 months. Why 3 months? Because we had an improvement of motor and sensory function, but as you can see, we had a CSF collection that we could palpate on the posterior part of the neck. So we just called the patient back to do a new MRI, 3 months. Then the things didn't go well with the CSF collections. He started to have a CSF fistula at the same point of the collection. And this was the new MRI when we went to see that. After we already tried with after the MRI at 3 months, the first duroplasty. No success of the repair of the dura, of the third surgery, and again, CSF collection increasing in size after 5 months. And the only way we could go away from this was to put a shunt, because after 2 revision surgery that were unsuccessful, with continuous CSF collection on the back and CSF leak, once we had controlled that no infection was in the CSF, after a few days of external ventricular drainage, we decided to put a EP shunt. This is after 1.5 years from this. With you see the Chicago Chiari outcome score, which is good, not that good, but especially the problem in this case was the complication that we could overcome only with a definite permanent shunt. So let's look now, not to go to take too much time to the experience. We did a long-term follow-up at Catholic University. Maybe some of you have read these papers that we wrote with Luca and Paolo, and last year, which was published. It was a revision of our casuistic with the follow-up of mean follow-up of 11 years. Only bony decompression, and in this case, you see that the syringomelia, so the patients with syringomelia was normalized or improved in around 80% of the cases without complications, with the Chicago Chiari outcome score, which was excellent in around 70% of the cases, and in a further more or less 30%, we had a functional outcome, as it is called in the Chicago Chiari outcome scores. We had to reoperate 3 cases out of 42, but in all the 3 cases, the operation was extradural, because we had a bone regrowth, and this, in 2 of them, and both of them were small children below 5 years. These are the children which are, in my mind, the most difficult for the bony decompression, because the bone tends to regrow in a much easier way than in a 10-year-old guy. And the third one was a 12-year-old girl, in whom we found a fibrous band that was reformed at the site of craniectomy. A few notes on when we do consider the bone decompression with the different indications. Again, in primary Chiari 1 with extremely small posterior cranial fossa, instead of doing simply an opening of the foramen magnum, we are used to do a posterior fossa cranial expansion beyond the opening of the foramen magnum in older children, with reduction of the thickness of the bone. This is our policies, in which we use a different kind of bony decompression, but still we can consider this bony decompression, so cranial expansion. This is one example of a 10-year-old guy before and 6 years after surgery with CSF flow on the back of the cerebellum. Obviously, in craniosynostosis, in secondary Chiari secondary to craniosynostosis, our indication is with closure of the lambdoid sutures to do occipital expansion associated to opening of the foramen magnum. And clearly this has, I would say, shared kind of indication by everybody in pediatric neurosurgery. In secondary craniosynostosis, again, it's a bony decompression with biparietal expansion. Different situation when we have complex Chiari with impressio basilaris, in which the indication, again, is decompression transoral, bony decompression, and posterior fusion. I would say it's not the case we are considering today, but just to say that bony decompression in a wider way, it's indicated in a different kind of Chiari. And then only some of the many meta-analysis, just to say what is in the literature and what is known by everybody. So we don't have a difference in the majority of this meta-analysis in clinical improvement between the two things. There is, in some of the meta-analysis, I will show you some of them, in better results in syrinx reduction with the posterior fossa osteodural decompression, but in this series, for example, this was not significant difference, and the incidence of recurrence is considered higher with the simple posterior fossa osteo decompression. And you see the clear price we pay if we want an earlier and rapid, in spite of the clinical grounds, reduction of the syringomyelia, of complications which are significantly worse with posterior fossa osteodural decompression. Again, some other of the many meta-analysis. It's one of the pathologies I would say in pediatric neurosurgery has more meta-analysis. Some of them like this, analyzing only pediatric patients, you see a difference in clinical improvement, better for osteodural decompression in this series, with the price of a longer hospital stays and a higher rate of complications, in particularly CSF-related complications. And again, some other series, there are not many differences between the overall results. The risk of reoperation without considering complications is higher if you try first to do bony decompression, but if you consider CSF complications, then the number of surgery you have to perform is higher if you consider posterior fossa osteodural decompression. And again, not many other things that are said, better improvement of syrinx in the majority of the meta-analysis, not significant differences in clinical outcome between the two, higher rate of complication with osteodural decompression. And just to show you how many in the last decades meta-analysis we have in the literature. And so just to conclude with our view, see again, some of the papers, meta-analysis, most of them are recent, in the last 2 or 3 years, have limited follow-up in consideration, a few of them a longer follow-up. So our most recent conclusions are certainly that there are different techniques. We have to treat different type of patients, and posterior fossa decompression is lower risks, less costs, and lower rate, in spite of a lower rate of early clinical improvement. But if you wait, you may arrive to a clinical improvement which is sufficient also in children with a larger syringomilia. So in children, we still consider posterior fossa decompression as the first choice in most of the cases. Our idea is that we are able to avoid major risk in more than 2/3 of the cases, and we are always in time to take them when justified. In other words, when we do have the join between clinical lack of improvement and not a sufficient care of the syringomilia. Thank you. So I think this is my view, and I am open to questions and to see the other side of the moon. Because so Ash.
Thank you, Gianpiero, for that thorough review of the pros for bony decompression alone. And thank you for sticking to time. I think we're going to have ample time for questions at the end. I would remind the participants that there is the Q&A tab that's available during the talks, and you can put your questions in, or you can, if you can't work that out, email them to me at ash.single@gmail.com, and I'll be putting the questions to our panelists at the conclusion of Professor Thompson's talk, which we'll now start. And that talk is that bony decompression is not sufficient in the treatment of a 10-year-old with Chiari and a syrinx. And if we could load Professor Thompson's slides, and there they are. Thank you, Dominic.
Great. So hopefully, can you see my screen? Is that?
Yes, we do.
Grand. Well, excellent. Well, again, yeah, hello to everybody, and to Sandeep and the Educational Committee. Thanks very much indeed for inviting me to the to this talk and this contest. Thank you very much indeed for attributing me with the physique that I can see on the poster there. I'm afraid if it came to a physical contest, Gianpiero would be winning hands down. But hopefully, as I say, I can at least do my best to try to rise to the intellectual challenge. The question, obviously, you know, Gianpiero has clearly illustrated, is that, you know, is bony decompression alone enough for symptomatic Chiari malformation in a child? And clearly, the basis of this debate really is a question of surgical technique, and I certainly will not resist to deal with that. But I think it's important to look at the surgical technique in context. And I think it's worth actually just looking at this underlying problem here. We have the problem here is a 10-year-old boy. He's got a Chiari with a syrinx, and we're told he is symptomatic. So I guess, you know, I think presented with a child with a Chiari, and I think all of us are recognizing this now, it's important to ask at the beginning, you know, does this child actually require treatment? I'm then actually mindful of, and I'm grateful to Michel Zarat here, who we were teaching together in one of the European courses not so long ago, and I don't think it was related to Chiari, but he brought up this concept of the difference between surgical strategy and surgical tactics. And I think that's relevant in this situation. What is our philosophy here in trying to deal with this problem? And then what is the surgical tactic? What is the technique of surgery that we're going to use to try and deal with it? Now, you know, as I say, we're not told exactly what this child's symptoms are, but as Gianpiero has illustrated, and I think all of us would agree, typically in a child, this is likely to be some combination of headache, possibly bulbar problems, and being a child, very likely scoliosis as well. And I think we know that headache can be made better by Chiari surgery. We know that the bulbar symptoms can be improved. And we also know that appropriately timed, so in younger children with an earlier evolution of their curve, scoliosis-associated syringomilia can also be beneficially affected. And this is just one of the papers that have dealt with that. So I think, does this child require treatment? I think the child is symptomatic and therefore does. Now, of course, we know that if the child was not symptomatic, actually the natural history of syringomilia in Chiari in children can be very benign indeed. And in fact, Ash and others have published showing that actually the natural history may be a little bit more benign than we've previously assumed. I mean, this is just one example of a child I looked after that shows this progressive, actual spontaneous improvement in syrinx over time. But clearly, that's in an asymptomatic case. When it comes to surgical strategy, I think, as I say, whilst the technique of foramen magnum decompression is absolutely we have to think about, I think it's also very important. I think we're increasingly recognized about the etiological heterogeneity of Chiari 1 malformation. And, you know, in the article that I wrote last year in the special edition of Child's Nervous System, you know, I pointed out there that actually what Chiari described, you know, in his famous and oft quoted monograph is very different to what we see now. I mean, he was obviously a pathologist, therefore looked at dead people, didn't look at imaging, he wasn't obviously a surgeon. And so I think the condition that, you know, is attributed to his name is very different to the one that most of us see these days. And I think, you know, it's important perhaps for us to redefine our definitions of Chiari. And in fact, this is one that I proposed in that article, that actually Chiari 1 malformation perhaps is better looked upon as a functional obstruction at the foramen magnum that may result in neuraxis compression and also altered CSF flow at the craniovertebral junction. And I'll come to that back to that at the end. But I think, you know, and again, Gianpiero alluded to this when he showed cases of craniofacial abnormality, craniovertebral junction abnormality. I think it's important to recognize, and I think this is particularly so in children, that there may well be underlying etiologies that we really need to look at, because if we accept that there are other etiologies, this means that we actually can garner and change our investigations accordingly, and that may well have a significant impact for the operation that we then choose to perform. Now, clearly not every child with a venous hypertension or a craniovertebral junction abnormality will require a specific treatment directed to that. And, you know, in the majority of cases, we will still end up looking to be doing a foramen magnum decompression. But I think it's very important in pediatric practice for us to be analyzing underlying cause and potentially dealing with that where possible. I've included the connective tissue thing here. Hopefully there won't be too many questions on that. As you know, very contentious at the moment, and I'm sure that's true in other parts of the world as well. But actually, how good are we at Chiari surgery? And I think, you know, it's quite salutary to look at some of the literature here. This is some from Columbia group, where they analyzed a whole large recent cohorts of patients and showed that actually the best outcomes, you know, in blue here, are achieved in terms of, and they looked at neurological, headache, syrinx outcomes. And for the most part, you know, in best series, one's actually achieving the surgical goal in 80% or more. But actually at the other end of the spectrum, if one looks at the worst outcomes, they're actually the surgical objective is sometimes, you know, not achieved in up to half of the cases. And I think, you know, this is perhaps a reflection not just of surgical technique, but perhaps in the choice of operation. So what should be our surgical strategy in this child? And I think definitely to try and determine wherever possible underlying cause and direct the treatment accordingly. Now, of course, you know, in this particular case, you know, we've decided the debate here is about foramen magnum decompression. And I think, you know, this is really a debate, you know, about, do you go big with the duroplasty and all the rest of it, or go small with a simple bony decompression? And I'm reminded of a paper from many years ago, because this is not a new debate, of course. And in fact, this paper from the Lyon group over almost 20 years ago now, this looked at, and along here are all variations on foramen magnum decompression, varying from simple bony decompression to much more aggressive intradural manipulations, arachnoid tonsilopecty, putting in syrinx shunts and so forth. And I think, you know, they showed here that actually at the benign end of the spectrum, just with bone opening alone, you've got moderately good results. And actually in your bad outcomes, because for each technique here, we've got improved, stabilized, or worst. Whereas actually, if you do a dural opening, you don't even put a duroplasty on, here you're getting a lot of bad outcomes for relatively few good outcomes. And in this study, they found that really probably the best was operation 3, which was dural opening with duroplasty. That gave the greatest overall good outcomes with respect to the smallest number of bad aggravated or adverse events. So in essence, you know, when we're doing foramen magnum decompression, we're trying to sort out this balance really between the safety of the surgery and its efficacy. And of course, in duroplasty, yeah, we know that actually that can be efficient in improving symptoms and radiological outcomes. But of course, the criticism of it is that the complications are somewhat greater. Of course, as Gianpiero says, by contrast with bone only, yes, definitely we're looking at increased safety, lower hospital admission time and so forth. But is that in any way compromising the outcomes? And of course, as Gianpiero has just said, there have been a number of meta-analyses, number of looking at multiple papers to try and resolve this question. So 20 years on, are these papers telling us anything new that we didn't know back from when Marc Sandou published his paper? This is just one of the papers, and again, Gianpiero has alluded to this already, that we can see that actually if you put, and this is a combination of adult and pediatric patients, that there was a tendency for overall clinical symptoms and imaging to be improved with duroplasty versus dural opening. And that seemed to be true whether one was having a syrinx there or not having a syrinx there. And in fact, when that was adjusted for adult versus children, again, a non-significant but marginal still improvement in favor of duroplasty. As Gianpiero says, the number of papers out there now trying to analyze this problem is enormous. And so I've just tried to summarize here some of the more recent meta-analyses. And what I've sort of summarized from them is really how the two procedures, duroplasty versus bone only, compare with one another in terms of their performance. Yeah. So in terms of clinical improvement, yeah, most of the papers seem to feel that actual clinical improvement, so for headache, motor symptoms, and so forth, it's pretty similar between the two techniques. When one looks specifically at radiological improvement, syrinx improvement, then across the three meta-analyses that actually looked at that, there seemed to be a consistent advantage for duroplasty over bone-only decompression. But of course, as we know, actually when you then look at the complication rates, yeah, then actually, and this is, remember, this is procedure performance. So duroplasty performed less well than bone decompression in a number in fact, across all of these studies. But of course, again, reoperation rates, duroplasty performed better than bone only. You are more likely to go on and have a second operation with if you've done a bone only decompression in these two meta-analyses. In the Kai paper here, there was actually no difference in reoperation rates between the two. So looking at the literature, it is all well and good, but there are significant limitations. And I know this title of this slide looks a bit provocative, but I think we have to recognize that surgically, there is an underlying fallacy sometimes in evidence-based surgery. If you want to do a medical trial of a drug, for cancer, for example, we can trial that in Rome, we can try it in London, and we can have an input of patients that is homogeneous, an output measure, and a same intervention. The drug applied in city A is going to be not so, if it will be the same as it is in city B. But actually, if one looks at surgical series, and particularly something like Chiari surgery, when you look at those meta-analyses and the individual papers, there's an enormous variability of input. There is selection bias. Some departments will obviously have more craniofacials, for example, or more craniovertebral cases. There's enormous etiological heterogeneity, and of course, a huge spectrum of age. And we know that the under 3s and 4s may behave very differently to the teenagers and the adults. The outputs are also extremely variable. Clinical is often quite nebulously dealt with. Sometimes it's pure radiological outcomes, the syrinx, and sometimes outcomes are measured in terms of complications, CSF-related complications, reoperation rates, etc. And of course, one of the big problems that we have in surgery is the variability of the intervention. This is not like a drug. And so the operation done in city A is not necessarily going to be comparable with the similar operation done in city B. And I think it's important to look at the underlying techniques of what we mean when we talk about dural opening, because there's an enormous variability of technique that is employed. Some open the arachnoid, some then, fiddle around with the arachnoid, open up the obex, tonsillar cautery, put in stents and so forth. There are variable materials used for duroplasty. Some people, as I said earlier, not using duroplasty at all. From my point of view, just as a point of technique, I must admit over the years, I've tended to use this T-shaped musculofascial incision, predominantly so that I can guarantee getting a fairly watertight closure and reducing that risk of CSF-related, leakage or pseudomeningocele. I certainly try to preserve the arachnoid going in, mainly to reduce the risk of any blood load going into the CSF and risking complications associated with that. And then, the duroplasty, I tend to use DuraGuard here, which is bovine collagen, but again, trying to effect a watertight technique so that I'm increasing the volume, increasing that space of the cisterna magna. And so, I then feel confident that with that operation, hopefully I end up with a radiologically improved cisterna magna and a demonstrable effect on the underlying syrinx. And of course, in a situation like this, where you've got a very extensive syrinx, one really wants to see a response, a radiological and a clinical response to that, hopefully as soon as possible after the surgery, which I would be worried with a bone-only technique that it would take greater time if that was going to decompress at all. And again, even with the bone only, there's significant variability. Yeah? A true bone only, just taking off the bone of the posterior fossa, versus I think what is now more commonly employed, this so-called dural splitting technique. And this picture is from the Neil Feldstein and Rick Anderson's group, showing the importance of actually removing these bands, forming these slits, trying to make the dura more expansile. And I'm sure if one's going to be doing a bone only technique, these are important manipulations to try and get as much expansion as that dura as you possibly can. But my problem is that, often when doing this, the radiological appearances are sometimes not quite as dramatic. I mean, here we can certainly see the gliosis of the tonsil here, a fairly full foramen magnum. And yes, one gets some improvement, but perhaps not as dramatic as one would with a duroplasty technique. And of course, there are some instances where, as I say, one can do a dural splitting operation. And you can see here, and these cases are courtesy of my colleague here at Great Ormond Street, Zubair Tahir, who's nicely shown this series of patients. And you can see, despite the dural splitting operation, this syrinx has progressed and only improved when, he went on to repeat with duroplasty. Of course, there are things that we can try and do to optimize bone only. Yeah, use the intraoperative ultrasound. I have to admit, when I use this, and I do use this, one gets these very nice pictures, but I think they're often difficult to interpret or use as a decision matrix to go ahead of whether or not one should go ahead and open the dura. And of course, without opening the dura, there's the risk of missing underlying intradural pathology. There's a paper, I think, back from the Jerry Oates group showing that intradural abnormalities present in up to 5% of primary cases, and a lot more in terms of revisions, where this sort of arachnoidal scarring would otherwise be missed. And clearly that needs to be addressed in order to improve the CSF flow at the level of the foramen magnum. Again, other means of trying to decide should you go beyond bone only is intraoperative neuromonitoring. We've published on this, as of many others, and I think none of us have really been able to find a consisting intraoperative neuromonitoring technique to guide us. So really, I mean, this sounds a little bit negative about the limits and the fallacy of evidence-based surgery, but actually, is there a possibility of improving or resolving this confusion? And I think there is. And I think one of the things is actually to look at one's own results, and that at least takes out some of the variability of the intervention if one's looking at one's own clinical series. And 3 years ago, we set up a Chiari clinic here at Great Ormond Street, and the neurologist undertook a review of headache outcomes from Chiari surgery. And there were 102 patients, 57 of whom had got a predominant headache presentation. And the overall improvement in headaches was around 75%. If you use the International Headache Society criteria for Chiari-associated headache, those outcomes were even better. But actually, when we looked at the surgical technique, we were getting more effective or more consistent resolution of headache with the duroplasty versus bone only. And in fact, it was in the bone only group that we ended up having to do the revisions. More recently, again, we've looked at the data. My new colleague, Dulu Silva, and some of my colleagues here have looked in a bit more detail at a large number of the Chiari patients here. We've actually separated here that sort of standard just bone only with the more recent technique that, as I say, Zubair has been doing here, usually looking at specifically bone splitting, and the numbers I accept are a little bit small here. The presenting symptoms, again, typical as we would think, syrinx and headache. These are non-selected for the procedure, so you can see a slight increase in the proportion of the syringomyelia patients undergoing duroplasty. But what of the outcomes? If one looks at the syrinx, so the radiological outcomes, yes, we're getting good regression of the syrinx in over 80% of the duroplasty cases, but not able to achieve that in the, with our technique of the bone only or even the more recent bone splitting, dural splitting, but clearly the numbers here are quite small. And I think perhaps also noteworthy is that then subsequent progression of the syrinx, we have found here to be more frequently a problem if one does bone only than if one includes a duroplasty in the original procedure. So what of the complications? Because of course that's going to be the big criticism here. Now, the requirement for further surgery, again, in keeping with our experience here and others in the published literature, revision rates are somewhat greater if you start off with a bone only compared with a duroplasty. Now, those numbers vary a bit across series. And of course, you might argue that when you've done a duroplasty, your options are a bit less than they are have you just started with a bone only. You can clearly always go and do more after a bone only. That's not quite so straightforward with a duroplasty. In terms of our complication rate here, yes, certainly the duroplasty did come out with slightly higher complication rates, but actually the serious complication rates here of things like CSF leak or bacterial or chemical meningitis, really quite small numbers here. And I think, partly attributable, I think, to that closure technique that I must admit, I do think improves the rate of CSF-related complications. There were some cases of post-operative hydrocephalus amongst these cases, and I wonder that may indeed be a failure of the surgical technique, but as I alluded to earlier, it may also be a failure of adequate recognition of the underlying pathology. Maybe there was an underlying CSF circulation disorder in some of these cases that should have been dealt with a priori. And then length of stay, certainly for the more recent dural splitting, there does seem to be an advantage of length of stay of bone opening over duroplasty, again, that's consistent with what Gianpiero has just demonstrated. So what is a pragmatic approach whereby one can try and resolve that confusion? And I think I go back to the importance, as I say, of actually, I think at the beginning, trying to define a strategy. What is going to be our philosophy for tonsillar ectopia? The importance of actually looking for an underlying cause. And I think this is particularly important in the pediatric population, and wherever possible, addressing that in the first instance. In terms of the surgical tactic, the operation, the technique that we then use to try and achieve that objective, I go back to the definition that I alluded to earlier. And I think that symptoms and signs in Chiari-associated syringoma, or in Chiari in children, they may well be purely compressive. So, for example, headache and bulbar symptoms. And I think it is not unreasonable in those cases to certainly consider a bone-only decompression with dural splitting. But I think one has to recognize that there will be an increased risk of potential reoperation. And I think that's something that's important discussed with families in advance. I think in situations where you have radiological evidence of altered CSF flow at the craniovertebral junction, by which I predominantly mean syringomyelia, here I think in order to get a more defined and consistent improvement of CSF flow across the craniovertebral junction, I think you can more predictably achieve that by incorporating a duroplasty into your original surgical procedure. So in order to answer the question, is bone-only decompression enough? I think the answer is it might be, but I think you can be, certainly our experience is, and I think, you know, that is reflected in the literature, that is less predictable compared with a duroplasty. And I think in this particular case, it's a 10-year-old with a syrinx. And I think certainly if there was an associated scoliosis, I want that syrinx to get better as quickly as possible to hopefully improve the natural history of the scoliosis and potentially make any subsequent scoliosis surgery safer. So that's me done. So that's the case for the defense. But thank you very much again, Ash. And so back to you.
Thank you very much, Dominic, for that absolutely comprehensive review of surgical tactics. I guess it was kind of the presentation for the offense, since it was really a more aggressive approach that you were advocating. Also, again, thanks to Gianpiero for his thorough review supporting bone-only decompression, and an especially large thank you to the 130 participants that we have had join the webinar today. I'm going to move on to the Q&A, and just a reminder to our 130 participants that you can use the Q&A tab to enter any questions while we're having the Q&A session, which we have approximately 20 minutes for today. So we'll get into the first question. It's a technical question, but it's from Dr. Adalberto Ochoa Diaz. When you do a duroplasty, what kind of tissue do you use for that duroplasty? So we'll start with Gianpiero.
Well, we attempt to use always autologous bone fascia, especially if we have a 10-year-old guy. When we do have enough tissue, we try to avoid, whenever possible, any alternative to autologous bone fascia. So that's what we do.
And to clarify, that's autologous fascia harvested from
muscular fascia. I was from the muscles in the neck.
From the neck muscles. Okay, and Dominic?
Yeah, I must admit, I've always used artificial graft. I have to say, I predominantly use DuraGuard, which is bovine pericardium. I must admit, I like the use of that. I think it avoids making some people use cranial pericranium, as you know, but I think that my worry of that is extending the incision. I have tried that on only one occasion, and interestingly, I had to reoperate because actually it was I got a quite significant bone regrowth in the pericranial graft, which required reoperation. So I must admit, I use an autologous graft, a DuraGuard.
The next question doesn't have a name attached to it, but I think we'll put it to both of you. Do you actually believe in dural thinning along with bony decompression? So in your own practice, do you believe that dural thinning has a positive impact?
You mean dural splitting or dural filling?
Yes, the question is posed as dural thinning, but I think it's that multiple dural split. Yes.
Okay, yeah. In my view, when I do consider bony decompression alone, I mean in all cases to do dural splitting. So this is included in the bony decompression. It should be. It's, I think, to be considered underlined, that's a second important step of the surgery. So dural splitting always.
Dominic?
Yeah, I would absolutely agree with that. And I think, you know, for any of us, you know, who've taken off the bone there, you know, there is almost invariably that thick transverse dural band at the level of the foramen magnum. And it's often not that difficult to actually carefully split that. I mean, sometimes it's worth doing that under the microscope. Of course, there is the risk of causing a dural breach if one goes too aggressively. But I think, you know, and in fact, that is one thing that I think sometimes with the ultrasound you can see after you've done that splitting, one can actually start to see some increased CSF flow behind the tonsil, which is reassuring. So I think most definitely, I think if one's going to do the bone only, be as aggressive as possible with that dural splitting.
Absolutely. The next question is from Dattatreya Mazumdar, which is there any role for atlantoaxial fusion as the primary procedure? Syrinx, where the syrinx you believe is due to craniocervical instability. I'll put it to Dr. Tamburrini first.
Well, obviously, only in selected cases. We don't consider it as primary surgery in primary Chiari 1 deformation. In complex Chiari, certainly, as maybe in one of the slides I showed, it's a different kind of problem. So instability should be dealt first, together with anterior decompression when the anterior decompression is significant. So I think this is meaning another of the confusing categories of Chiari 1. It's really a different thing, a different scenario. So certainly but only in those cases when we do have complex Chiari, when we do have instability, yes.
Yeah, I think I would echo that. I suspect this question is a reflection of the work and the publications of Atul Girl, who, as you well know, is quite outspoken in terms of the role of cranial, particularly C1, C2 fixation. I mean, he regards it that is present in almost all cases of Chiari, and that you can address that by doing his distraction and internal fixation technique. I have to say, personally, I think that's an over-aggressive philosophy. I think it's unnecessary in the majority of cases. I think Doug Brockmeyer's group have come out with some very nice radiological paradigms to try and assess or define this so-called complex Chiari when you look at the Grab-Oakes line and you know, the clivoaxial angle and so forth. And I think there are certainly radiological indicators of where you do have an underlying craniovertebral abnormality. And I go back to the algorithm I showed earlier, that in those cases, you know, those rare cases, certainly, I think certainly fixation would have a role. But I think in an otherwise radiologically normal craniovertebral junction, no, I don't think there's a role.
Very good. The next question is from Kenichi Nishiyama. And I think it's an excellent question. Are there any special techniques or examinations to know the presence of arachnoid scarring before surgery? Gianpiero?
Well, even with the high definition 3D MRI scans, I will say I was not able, as we did in one of the cases, also the case I showed with it had complications after the duroplasty. We did a very thin slices 3D MRI scan to see if there was anything wrong, but actually we were not that at the end convinced by the MRI high definition. It was done with 3 Tesla high definition. I would say not only cineflow but 3D scans, and so in my experience, it still leaves some doubt. So I don't know, from basic anatomical MRI scans, I didn't have any really sufficient information that I would say it will help for sure. I'm not convinced.
Yeah, I must admit, that's my experience here too. I know there'll be a number of people listening in on this who swear by CIS flow studies and cine flow studies. these are all very qualitative investigations, and they're often very nice when you've got sequential scans, because then if you look at a post-operative compared to a pre-operative, you can sometimes see that improvement and flow. But I think as a determinant of whether or not there's underlying arachnoid adhesions altering CSF flow, I must admit I've not been convinced of that myself. And similarly on ultrasound, I think it can be very difficult to predict whether or not you're likely to see those arachnoidal bands. And they're important to know about, because I think particularly where there's a syrinx, it's important that those are dealt with as part of the restoration of CSF flow.
I think our next question is going to be a paraphrased question that multiple people have asked, including Dr. Mathumkar, Jose Miguel Mueller, and Suresh Sankla, which is intraoperative ultrasound an effective way to decide on the spot whether your bony decompression plus or minus the dural thinning or multiple dural cuts is sufficient, or on the spot use the intraoperative ultrasound to decide to move on to an open duroplasty plus or minus an intradural type of operation on the tonsils? So to paraphrase, is the intraoperative ultrasound a point of care decision-making tool that is effective? Gianpiero?
Actually, we are using intraoperative ultrasounds in all cases, but the main reasons we are using it is to look at if we were sufficiently lateral. So if we see with moving the ultrasound probe, the lateral, we try to see if we were sufficiently lateral in our bony decompression. It's obvious that in all cases, almost in all cases, you do dural splitting, you will see the tonsil pulsating. But it's not enough for me to change the view. It's especially we look at it to be sure that we have done a correct bony decompression, which means not only midline, but being lateral to the craniocervical junction.
Yeah, I must admit, as I said in the talk, I think it's difficult. I don't think we have found a good intraoperative discriminator as to when to stop with bone only and proceed. I use ultrasound mainly often at the beginning to check that I've reached the bottom of the tonsil, that my exposure is sufficient. I think certainly in my hands, I've not found it a good enough or sensitive enough discriminator on whether or not to go ahead with opening the dura. And similarly, with intraoperative neuromonitoring, yes, one occasionally sees some changes, but they're very difficult to, I think, interpret for an on the spot decision.
Okay, thank you, Dr. Muller, Dr. Campos, for that great question. The next question we'll move on to is with regards to durotomy without duroplasty. So the older technique of opening the dura and leaving it open, and as a strategy to increase the CSF space. Do either of you advocate or have any thoughts about that technique? We'll start with Dominic for this one.
Yeah, I mean, I must admit, at the risk of offending any colleague, and please forgive me, anybody who uses that. For me, that is probably the worst of all worlds. I think by opening the dura and leaving the dura open, I think, you run the risk of blood getting into the subarachnoid space. I think these people have a terribly uncomfortable post-operative course. I think the risk of aseptic meningitis is higher. You look at the papers where this is advocated as a technique, and the CSF-related complications, pseudomeningocele, hydrocephalus, seem consistently higher. And I must admit, I personally think, as I said, for me, I think that's the worst of all worlds.
Gianpiero?
Well, this is exactly the case of no clash with Dominic. I would have repeated exactly his words. I've never used it. I think it's the worst thing you can try.
I agree, but thank you very much to Shailendra Magnum for that question. Okay, Victoria Testa is asking, does Chiari surgery improve scoliosis when there is no syringomyelia? So it's not the context of this debate, but it's a separate question. But do you think Chiari surgery can improve scoliosis when you do not have syringomyelia? Gianpiero?
Well, when you do have Chiari 1 without syringomyelia and you do have scoliosis, you should look if there are other possible causes for scoliosis. So in the cases we had that arrived with Chiari 1 and scoliosis, mainly with the patient for the scoliosis and the shortening of the vertebral column had an associated Chiari, but operating for the Chiari did not change anything in the scoliosis without the syringomyelia.
Yeah, and actually, a short answer from me: no. I don't believe that when you've got when you don't have the syrinx there, I do not think there's an association with the scoliosis. And I think another important point in that as well, because sometimes the orthopedic surgeons come back and say, "Oh, well, you should deal with the Chiari anyway, because that means my scoliosis surgery is going to be more risky if you haven't dealt with the Chiari." And I have to say, I don't think there's any evidence to support that association, particularly in an otherwise asymptomatic individual. So I must admit, I don't recognize that association.
Our next question, I think I'll paraphrase Dr. Mathukumar, Dr. Natarajan Mathukumar, which is, do you think there's an age limit that influences bony decompression versus duroplasty? Is there an age where one or the other is more indicated? Dominic, we'll start with you.
Yeah, I thought that is a great question. I must admit, as the trainees that work with me here will know, I have this aphorism, always beware the Chiari and the child under 5. I think that the very young children presenting with Chiari, with or without syrinx, I think they're a group to approach with caution. And I think this is a particular group where you really need to be looking at all the possible causes. And I think it's a group that are much more likely to end up with CSF-related sort of circulation type problems, and that may be because there's an underlying CSF circulation problem at the beginning. And I think if there's a group that I would be more in favor of just doing the dural splitting for, it's the ones with compressive type symptoms, as I said earlier, bulbar, headache only with no syrinx, but also the very young ones. I think that's a group that one has to be really quite careful. Interestingly, there's a kid we've had in just this week. He's 4 years old. He has got quite clear tonsillar ectopia. He's got a huge syrinx and was brought in. He's rather irritable. We've done ICP monitoring on him, and his pressures are between 30 and 40. And his ventricles look normal. He appears to have some synostosis of his midline sutures. And so there, I think a foramen magnum decompression would quickly get you into a lot of problems. And I think, therefore, again, one needs to be looking at the underlying cause there rather than just simply treating the effect.
Gianpiero?
Yeah, exactly. Children under 5 are maybe I can say a few things about this also during my presentation, are difficult. They're difficult because they are the category also that shows a higher rate of bone regrowth. And so in this context, also bony decompression has the higher risk of needing a second operation because of bone regrowth or even the reformation. Tissues are different in a smaller child, and the chances you need to reoperate are high. And I totally agree that in a child like the one that Dominic just named now, probably with this high intracranial pressure, it's not indicated to do simply foramen magnum decompression. Maybe cranial expansion, in any case, would give the best results. So it's a different kind of bony decompression.
Thank you. So that is a great segue into two questions from two different people that are somewhat similar. That's Ashwin Chiari and Snigdha Saha, who are asking questions about hydrocephalus. And essentially, what is the patient where you think ICP monitoring should be done prior to any kind of foramen magnum decompression, so that you can anticipate or try to avoid pseudomeningoceles or CSF leaks? Gianpiero?
We don't used to do ICP monitoring. If we have a child with hydrocephalus and Chiari, we treat the hydrocephalus anyway without having first monitoring. So it's simply what we do think is a positive kind of factors working together. We don't know if the egg is Chiari or the chicken is the Chiari, but they are going together, and you have to deal with the raise of the intracranial pressure. So you need to balance that. In all these cases, we do third ventriculostomy first.
Dominic?
Yeah, I mean, clearly where you've got clear radiological evidence of hydrocephalus, it's a no-brainer, but often one doesn't, and the ventricles are not necessarily that big. And I think, you know, I think clinically sometimes if it's a very atypical headache, I think, you know, these days we have a very low threshold for getting formal ophthalmological evaluations on these kids just to sort of see if there's any evidence of papilledema and so forth. There's a paper, I think, from David Frim, who looked at actually failed Chiaris and the number of them that had an underlying BIH type picture that subsequently responded well to either shunting or ETV. And I know the Liverpool group have published some very nice evidence that preemptive ETV in some of these cases can resolve the symptoms without you going anywhere near the foramen magnum. So I think, you know, again, you know, as I said, with all those other etiologies, it's just a question of actually having it in the mindset, you know, have I excluded raised ICP as a possible underlying cause here? Because there'll be no quicker way of getting a CSF related problem than doing just a straight foramen magnum decompression in that instance, I would be my view.
Very good. So our next question is from Trimurthy Nadkarni. And that's, what are the options if a bony decompression and a duroplasty fail? What would you do in that case? I think we're going to have to assume that the patient continues to be symptomatic in a neurological way from their syrinx. Dominic, if both a bony decompression and then a duroplasty fail?
Yeah, I think by the time you got to that situation, again, I think, you know, you go back to first principles. You know, have I looked at all the possible underlying etiologies for this Chiari and syrinx in the first place? You know, have I missed a craniosynostosis? Have I missed, you know, a craniovertebral junction abnormality? You know, something like that. So that would be my first point of call. I think if I've excluded those and I've still got a big syrinx and a symptomatic patient, I think actually those are circumstances where, you know, it's not my favorite operation, but I think a syrinx shunt, you know, either syrinx to subarachnoid or syrinx to pleural shunt can be effective. It'll bring the syrinx down. It was done with a slight reluctance because it almost makes one feel that you've missed the underlying cause. Again, you're treating the effect rather than the cause. But I think you know, that would probably be my you know, my algorithm of thinking in that scenario.
Gianpiero?
Well, the first we'll consider to go and see if there is really a reformation of scarring, or arachnoid scarring. So we will consider a reoperation to look for a new scarring at the site of the surgery, and as a third option, yes, cerebrosubarachnoid shunt.
Very good. I think we're about to almost 10 minutes over time, and I think we've had a great set of questions. I'm going to be selfish and ask a question that's, I think, been in my mind over the years, and probably the two of you are the best equipped people I know to answer it. Over the years, we've watched as the bone-only procedure has become more and more popular. I think we've seen that when we go to the ISPN and watch the talks. We've seen it from the surveys that the ISPN has done. And I want both of you to look into the crystal ball and try to imagine for our audience what you think is going to happen over the next 10 to 20 years with syrinx and Chiari surgery. Do you think we're going to continue in the bone-only direction? Are we going to see the pendulum swing back the other way, or something else? Gianpiero?
Well, I think that what will improve is our capacity to recognize the etiology and differentiate the things. And if we are looking specifically to a primary Chiari 1, I think the number of complications with uroplasty and arachnoid scarring have been not changed that much, have not reduced in spite of improving of the surgical technique. So I would say that if we are talking specifically only of a primary Chiari 1, the way will go again in the direction of the bony decompression.
So more of the same is what Gianpiero believes is going to happen. And Dominic?
Yeah, I think quite rightly, you know, as I showed in the talk, you know, none of us have got perfect Chiari outcomes. You know, up to 20%, you know, may have not necessarily a complication, but you just may not have achieved your surgical objective. And so I think, you know, the drive to try and reduce complication rates and increase efficacy will clearly and importantly be there. I think part of that will be stratifying. I think increasingly, you know, I think, and in fact, it's one of the areas where I think pediatric neurosurgery has led the adult. You know, I think we're looking at now recognizing that it is a much more etiologically heterogeneous condition that we're dealing with. And I think, you know, hopefully there will be paradigms where the investigations, you know, the radiology can be helpful, and to the extent that we may be able to predict, you know, which child is better for a bone only, which is better for a duroplasty. And as neurosurgeons, you know, I would hope that we would be open to both techniques and not just staying single-minded and battling away on one of them.
All right, absolutely superb presentations by our speakers. We'd obviously like to thank our audience, who was very large and who put a lot of questions up, some challenging questions and some very interesting questions. Thanks go out to our education committee of the ISPN that organized all of this, and to Kenez. And then I'll pass it on to Nelsie for some final words.
Thank you, Ash. Thank you very much. Are you listening to me? Thanks for the speakers, and I would like to be selfish a little bit. I know it's a complex situation, the Chiari, and don't have all the answers. I would like to hear from Gianpiero about the bone fixation. You show us titanium plates. Did you use always, or did you use sometimes absorbable plates too?
Well, it was shown in cases in which we do have a very small posterior cranial fossa, and we don't think simply opening of the foramen magnum, but it's particularly in older than 10 years old guys, so from 10 years on. We never use this in smaller babies. In over than 10 years, maybe a little bit less than this, the problem might be that you do have bone movement if you do use only resorbable plates. So in older children that we consider this kind of posterior cranial fossa expansion, yes, we do use those. Also because in this fully grown child, you have not that high risk of having problems with titanium plates. Also, these plates are under the muscle, so they are not going to have the problems of pain, local pain that we do see in many other cases in which these plates are used under the skin. So only in adolescents in more than 10 years, because in those cases we do have the risk of resorption of the resorbable plates and movement of the bone.
Thank you very much. Dominic, please, congrats also. You show very beautiful cases, and my question is, you never opened the arachnoid? And the second question, if you see once the just herniation of the cerebellum and worse the postoperative period, I saw only once, it was a young adult, but it was necessary to be back and put a cranioplasty in place again. did you saw some complications, or did you have limits on your craniotomy before opening the dura, the transversal sinus exposed or not?
I guess in answer to the first question, as I say, maybe I didn't make myself clear in the presentation. My preservation of the arachnoid is during the opening of the procedure. I must admit, I do feel that some of the complications, the aseptic meningitis, the hydrocephalus, I think some of that is related to getting a blood load into the CSF during the surgery. And so I try and preserve the arachnoid, certainly through the initial part of the procedure. And then, once I've done that, then I will open the arachnoid to make sure that there aren't any bands there. I won't routinely coagulate tonsils and won't do anything more intradurally, unless there was scarring or something there. I've not got any experience of doing the bone augmentation technique that Gianpiero discussed. I must admit, for me, I often teach, and the importance of the decompression is width rather than depth. And I think it's those very, very deep craniotomies that go terribly, posterior fossa craniotomies that go very high, where one gets the risk of that, that tonsillar descent, that cerebellar slump, or as it's sometimes caused. But I have to say, I must admit, in pediatric practice, I have not fortunately had to deal with that. And I guess it's interesting that the patient you say is a young adult, and I wonder if it's a problem that's slightly greater in adults than children.
Okay, thank you very much. Congratulations for all the speakers. Thanks, Sandeep, for this Clash of Titans. Excellent moderation, Ash. And maybe you can give the final remarks if you want. It's perfect for me. Thank you very much. We all learn a lot from you. Thank you.
Thank you very much, Nelson.
Okay. Thank you.
Thank you very much. I'm speaking to you from the car. I just wanted to say thank you to everybody and to remind you, in a fortnight from now, we're going to be debating about ETV. I think Linda's going to share the screen with you. And
your sound is not clear, Sandeep, but...
I think he wants to say something about the next class.
So if I can just...
The next...
Yes.
Well, I think what Sandeep is trying to say to everybody is that please join us on July 17th at the same time, same platform, where Abea Kulkarni and Connor Malucci will be debating ETV without CPC. And Sandeep will be moderating that, hopefully from a very strong internet connection. So we look forward to seeing everybody then. But thank you to everybody, and everybody have a good day today.
Thank you,
Fantastic.
Ash. Thanks, Elsie. Cheers, Gianpiero.
Thank you.
Bye-bye.
Bye-bye.
Bye, everyone.